Hello, everyone. Happy Friday, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Today's webinar features Dr. Peter Green, who is a board-certified radiologist, as well as Brent Garvin, Senior Product Manager for Planmeca, and they will be discussing the diagnostic and treatment advantages of 3D imaging. At any point during the webinar, if you have a question, please type it into the Q&A section, and we'll answer it live at the end of the presentation. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. And lastly, this webinar is sponsored by Planmeca. Dr. Green and Brent, welcome.
Thank you, Adam. Appreciate it. As Adam mentioned, I'm Brent Garvin, the Senior Product Manager for Imaging for Planmeca in North America. And I'm here with my good friend, Dr. Peter Green, oral and maxillofacial radiologist. And we're delighted that you could join us today on our lecture on 2D pans leaving you flat, why now is the time to see your patients in 3D. So today we're going to cover a lot of information in a short period of time, but the main things that we want to make sure that we get to you is we want to make sure that we compare 2D versus 3D for the visibility of anatomy, diagnostic accuracy, and radiation dose. And we also want to make sure that we cover the best practices for you to determine when 3D imaging scanning is appropriate in your practice. And then when we have time at the very end, we'll wrap it up with some case studies so you can see some examples of using this 3D technology in your practice and how it can help you with better treatment planning. So before we go ahead and get started, Dr. Green, if you don't mind just sharing with everybody a little bit about yourself.
Yeah, of course. So I am a dentist by background. I did my dental school training at the Medical University of South Carolina in Charleston, South Carolina, and then did a 3-year oral and maxillofacial radiology residency program at UNC Chapel Hill. I'm board certified by the American Board of Oral Maxillofacial Radiology, and currently I'm in private practice with oral radiology consultants, as well as volunteer as an adjunct faculty at UNC.
All right, thank you. So we are here at Planmeca's North American headquarters in Hoffman Estates, just outside of Chicago, Illinois. And this beautiful facility is home to a fantastic showroom where we invite doctors to come in and put their hands on this actual technology and can feel it, touch it, and get comfortable using the technology before it's implemented in their practice. But more importantly, once they make a decision to implement this sort of technology, we can't forget about education. So we have fantastic educational facilities here where doctors can enjoy hands-on experiences as well as with their staff using the software so they can get a faster return on their investment. So we welcome everyone to have a chance to come to Chicago, and we'll welcome you here at Planmeca. So speaking of education, I know it's an important topic for me as well as for you. And it's great that we have you here to give your insight, your perspective from a radiologist standpoint of how 3D is going to impact the everyday dentist. And so many dentists, I got to say, one of the things that they come back with regarding 3D for starters is they feel like they don't need 3D. So can you tell us what dentists are using cone beam for today?
Yeah, of course. So in terms of cone beam, a lot of dentists, purchase a cone beam machine mainly to place implants. But once they purchase that machine, they find out that they can use it for a lot of different aspects of their practice. So they start with implants, but you can also use 3D imaging to look at endo for endo treatment planning, as well as third molar extractions. And apical pathology as well. So apical lesions are really easy to pick up on 3D, as well as TMJ issues and cases of trauma and orthodontics as well. A lot of people are using 3D to see where they can move the teeth in the maxilla and mandible. And then airway is another big factor that's kind of come to the surface for 3D imaging.
All right, perfect. So when it comes to 2D imaging, one of the studies I wanted to share up on the screen that everyone can see is this is an interesting study that was done in the International Endodontic Journal, and they were looking at 2D x-rays and how they compared to taking a 3D cone beam. And what they found in the study is that when it comes to, let's say, a periapical lesion detection, the 2D intraoral x-ray, which is considered the gold standard in our industry, is only 25% accurate, which is astonishing to think that 75% of the time they may be missing what they need to see from a diagnostic standpoint. And only cone beam allows 100% accuracy of that. So another interesting study that I came across is when a clinician makes a decision for a patient for treatment planning, and then they take a cone beam, 62% of the time they change their treatment plan based upon the image that they got from their cone beam unit versus that two-dimensional x-ray. So these are huge statistics. Can you share, like, why is it so much better than 2D?
So it's funny that you asked that, because that's a question that's gone back decades. So there's actually an article written in the early 60s, 1961, that found that apical lesions can really only be seen once that lesion reaches the outer cortex of bone. So if you have a small lesion just within the cancellous bone, you cannot see that radiographically. So suffice to say that large areas of bone loss, extensive disease of bone, may be present even when you can't see it on 2D radiographs. And there have been some other studies as well, but we can look at some examples right here just to kind of illustrate that point. So this is tooth number 14 was symptomatic. And so on a periapical, we can't really see much going on with the roots of the teeth because of some anatomic superimposition over those roots. But if we take a cone beam, we can actually see that there is a large apical lesion near the distobuccal root. And here's some other examples as well. So we could see, what looks like a smaller apical lesion associated with that maxillary molar in the PA. But if we scroll through the cone beam, we can actually see that there's a lot more bone loss there than we first realized. So just kind of scrolling through the different roots, we can see that that's a pretty large abscess that you can't really see on 2D. Here's an example of an old pan. So this patient had some symptoms in the upper left, and again, with anatomic superimposition, we can't exactly see what's going on with the roots of those teeth. But if we take a cone beam, we can clearly see that there's a lesion associated with those apices on number 15. And then just this last one kind of showing an ortho component. So this was a pan taken for a patient that was undergoing ortho treatment. But if we take a look at the anterior maxilla there, it only looks like there's 6 through 11, the normal teeth that we expect to be there. But if we take a cone beam, cycling through those slices, we can actually see that there is a supernumerary tooth in the anterior maxilla, and which we did not see on the pan.
All right. So according to you, your opinion, all of the research that's been published, as well as what your peers feel, that 3D seems to be better for the patient than two-dimensional x-rays. Why do you think that dentists are reluctant to get into this sort of technology if it seems to be better for their patient care?
Yeah, so I think it comes down to their initial comfort level. They feel comfortable reading a 2D image. And they might not want to make the jump to 3D because there's a little bit of a fear factor in there. They don't feel like they have the training to review a 3D scan. So personally, that's what I've encountered.
Okay, so if they're comfortable reading a two-dimensional pan, and I think most dentists today have a 2D pan in their practice, and that's what they're comfortable with, condyle to condyle, let's say, and looking at that for gross anatomy, wouldn't it kind of make sense for them to, if they're going to look at 3D, maybe look at a field of view that maybe mirrors what they would see in a pan to make it a little bit easier?
Yeah, that's a good point too. So I've seen a lot of dentists go to a medium field of view as well, because that mimics the field of view that you would expect to see in a pan. So instead of needing to take a full skull CBCT every time, a lot of these dentists are actually buying medium fields of view that can collimate or narrow the focus down so they're only seeing condyle to condyle and maxilla and mandible.
Oh, okay, all right, that's
Yeah.
perfect. So we actually have, Planmeca has a Promax 3D Plus, and it's 10 centimeters high, 20 centimeters in diameter.
Yeah.
And we're seeing a lot of popularity with that type of field of view, and that might explain it because it's probably replicating that pan view that we're seeing here, but in 3 dimensions. And what's really nice about that is we kind of classify it as like a career cone beam. So if a dentist is looking for something that can grow with their needs into the future, if they outgrow this field of view size, let's say, or they take on some other application or need inside their practice and they want a larger field of view, they can take that Promax 3D Plus up to a larger field of view and basically get the entire skull. So do you mind sharing with the viewers some images of what 3D images look like compared to the pan that they're used to, and maybe show us like a side-by-side comparison of a pan versus 3D images?
Yeah, of course. So, just to start out with pans, we can actually see a lot of anatomy. There's a lot to see in panoramics, but it can be difficult to read, in my opinion, just because we have all of this superimposition of all the anatomy. So let's kind of take a comparison between 2D and 3D here. So when we're looking at a cone beam, we're looking in these different slices. So the coronal in the upper left is like you're looking at the patient. Axial is like you're looking up at the patient, and then sagittal is from the side. So that's just to kind of orient you a little bit. But let's go through some structures that we can compare between 2D and 3D. So in this pan on the left, we can see the septum in the middle of the nose. And on the right, we can see in the 2 different slices of the cone beam, we can see that there's the nasal septum right there in the middle. And then moving on to the rest of the nose, we have this radiopaque object in the nose. That's the nasal turbinates. So what we see here in the pan is actually what we see here in the cone beam. And then also you can actually see the airway in pans as well. Here would be the nasal pharyngeal airway. And so that corresponds to this area right here. The oropharynx is this shadow right here in the pan. We can actually see that here in the 3D as well. The soft palate, draping off the back of the hard palate there. We can see that in the pan and the 3D. This is what's really interesting though. So this patient, when they had their pan taken, they did not put their tongue to the roof of their mouth. So they ended up with this airspace artifact that's superimposed over the maxilla. But the nice thing about 3D is this patient had their tongue, not pressed against the roof of their mouth, but we can still see the apices of those teeth. Maxillary sinuses, we can see in the pan here on the left, as well as the CBCT slices on the right side. And then taking a step back, we can actually see some anatomy outside the jaws. So the styloid process here behind the jaws, and we can see that on either side in both slices of the CBCT, as well as this is where the some muscles attach, the muscles of mastication. So these attach to the pterygoid plates. And again, all of this is much easier to see on CBCT than on pan. So we have the Zygomatic Arch here in the top right of the pan, and we can see that, clear as day on both of these CBCT slices. Behind the condyles, we see the mastoid process behind the condylar head, and that is what we see in these CBCT slices here. And actually with pans, we do see part of the spine. So we can see some of the cervical vertebrae there. So again, pans aren't limited just to the jaws. You can actually start to see some of the cervical vertebrae as well. So here we see the vertebrae in the CBCT slices. So we're actually seeing, all of these with much more clarity than we do with a pan. Here we see the, maxillary bone, the alveolar bone, and that's what that would look like in the axial and coronal slices, as well as the teeth, right, the dentition. You can see the apices down here in this sagittal view. And then the hard palate, which I alluded to earlier, we can appreciate that really radiopaque object here in the panoramic. And then again, we can see that here in the CBCT. And then there's a little canal between number 8 and 9 in the anterior maxilla. So it just kind of looks like this diffuse area of radiolucency, but that is what we see here on the cone beams. That's the Nasopalatine Canal. And then going down to the mandible, we see the TMJ, right? So the mandibular condyle, the fossa where the condyle sits, as well as the articular eminence where the condyle slides down when we're opening our mouth. And then just in front of that, we have the coronoid process, which we can see here in the panoramic image, as well as the CBCT slices here. The ramus of the mandible, of course, we can see that easily in the sagittal view here on the CBCT compared to the pan on the other side. And this is a really interesting one, especially for those placing implants. So this area that kind of looks diffuse and radiolucent in the mandible, that's actually where our salivary gland sits. And so this corresponds to this little depression of bone. And so it's helpful to know in 3 dimensions how big this depression is, so we know if we need to angle our implants. And then we have the IAN, the mandibular canal, which goes to provide innervation to our lower teeth. And then the mental foramen here in the panoramic, we can see it, this little radiolucency, and that is what we see in this cone beam here. And then lastly, we see the hyoid bone, which is below the mandible, and we can actually pick that up in our pans. So again, a lot of anatomy outside of the jaws, but again, much easier to see on cone beam.
Yeah, that's great information. I appreciate you sharing that with us. If we go back to the beginning, when we started, we kind of talked about fear, and I know that that's on a lot of dentists' mind, of getting into the unknown and scan interpretation, so on and so forth. Mm-hmm. And that's why we do courses here on a regular basis. In fact, you and I have one, I think in just a few weeks here at Planmeca, where we have dentists come in and they learn how to go through scans and all of that. What's the basic rule of thumb for a dentist if they take a scan? What's their obligation? Because they all think they have to send them off to a radiologist every time they press the button. So mm-hmm. what's the typical rules of thumb on that?
Yeah, so a good rule of thumb is to treat a CBCT scan just like you would a pan. So I recommend starting on one condyle and working your way over to the other condyle. And while you're doing that, just evaluating the apices of all of those teeth, just looking for any asymptomatic abscesses that you might encounter. But if you do see something that you don't know what it is, I think it's important to know that you don't have to diagnose it or don't have to know exactly what it is. You can always send those to a radiologist for review, but just know that you don't have to diagnose, and you don't have to send every CBCT to a radiologist for review.
All right, well, that's good to know, and it's good to hear that you say something like that, because that does seem to be a hot topic of that obligation. So speaking of best practice, when it comes to taking a 3D image, what is traditionally the best practice for a dental office when it comes to taking 3D? Can you give us some guidance on when they should take a 3D versus maybe shouldn't take a 3D? Yeah,
so almost a decade ago, there was an article written in JADA, the Journal of the American Dental Association. And so the ADA specifies what they suggest for the use of CBCT in dentistry. And so they suggest that using 3D imaging, it should be considered an adjunct or a supplement to the traditional 2D that you see in your offices on a day-to-day basis.
Okay, interesting. So I find this topic, this portion of cone beam fascinating, because when I see these sort of guidelines, whether it's anything in healthcare, medical or dental, that these sort of guidelines, it's safe to assume they're written from a standpoint of radiation, right? They're establishing these sort of guidelines based upon radiation dose to the patient.
Right.
And one of the things that we're proud of at Plan Mecca is we created what's called ultra low dose. And it's like an evidence-based technology that we have built into our machines, where we've successfully driven down the radiation levels to be, in some cases, less than a 2 dPa that's taken in the mouth with a sensor. We can take larger fields of view that replicate that of a pan with less radiation than if they were to take a 2D pan.
Yep.
And I personally just think that this could be like a paradigm shift at this point in the world of imaging, or maybe on a more routine basis. I mean, do you see that maybe dentists, if we've driven down that radiation level to be that low, that they could possibly use this on a more routine basis?
Yeah, I think you bring up a really good point. So I think what you're referring to is the Ludlow study from UNC. So there was a study that looked at ultra low dose compared to standard scanning, and they found that there was an average reduction of dose by 77%. But despite that reduction of dose, there was no loss of image quality. So the ultra low dose scan had similar image quality to the ultra low dose. And then since that time, there have been some other studies too, as well, looking at low dose for pre and post endo treatment planning. So they found that low dose back in 2020, there was a paper written that said low dose CBCT mode does not seem to negatively impact your idea of image quality with those scans, as well as for pre-implant site assessment. So using low dose to evaluate bone levels prior to implant placement is another good tool to use for ultra low dose as well. So this study back in 2017 found that there was really no difference in bone measurements using standard and low dose protocols.
Fantastic.
Yeah.
So I think we got plenty of time. There's no need to rush through any of this stuff, because I'm sure those that are attending this would just love to see some sample scans, if you have some that we can kind of go through and kind of, show clinicians, what they would see on a two-dimensional X-ray versus what these 3Ds can do for them.
Yeah, sure. So let's look at a few. So in this first case, this patient was 39 years old and had persistent pain in the upper left. So where she had previously had root canal treatment. And so first off, the dentist took a PA, and we can see, clear as day that there is a short fill on that canal, and we do see a radiolucent lesion near the apex. But here's the interesting part. So this tooth was the area of interest. So when we take a 3D scan, we can see that there's this issue, but then we also see some asymptomatic abscesses as well. So where I'm scrolling right now with the mouse, I'm looking at the apical lesion associated with number 11. And we can see that there's the gutta percha in that canal space, as well as that short endofill, right? So we see that canal that doesn't have obturation material. So there's the apical lesion associated with 11. But then as we scroll through, and this is just a small field of view, we can actually see more issues as well in terms of endo that may need to be retreated. So associated with number 9, we see that lesion there as well. And the area of interest was just tooth number 11. And then right at the edge of the field of view, we can actually see that there is a lesion associated with tooth number 14 as well. So just at the corner of that field of view, we can see that there's that that radiolucency there. And this was just in that, small endo, in that small endo scan. And again, looking at low dose or ultra low dose, the dose for this small field of view ultra low dose scan was about the equivalent of a PA. So moving on to case number 2. This patient was in her 30s as well, with pain in the upper left, and the dentist was able to localize the pain to number 14, but they chose to take a slightly larger field of view, so medium field of view. And so again, first they have a PA, and so we could see a little bit of a short fill on that palatal root there. So again, medium field of view CBCT, and scrolling through, our area of interest is the upper left, tooth number 14. And so just kind of confirming what the PA showed, we see at that palatal root, the fill was a little short there. But again, because we're kind of bumping up to a medium field of view, we want to check for any other issues as well. So we're looking at tooth number 14. We see that short fill with the palatal root. And then I'll zoom out in just a second here and check the other side for any other issues. And so scrolling down, just checking for any other sources of pain, we could see in that upper right window, we could see an apical lesion at number 19. So where my mouse is hovering right now. So we see that apical lesion associated with 19, as well as a little bit of PDL widening on the tooth behind it, tooth 18. And again, that was all on one side. That patient was symptomatic in the upper left. But with cone beam, we could see that there are a few more teeth that might need to be addressed. And then we have this third case. And so this is kind of going with a larger field of view just to kind of round us out. So this was an older patient who had jaw pain. She had jaw pain on both sides. And also in her clinic note, it said that she was complaining of bad breath or halitosis. And so because she had pain throughout her jaws, the dentist decided to take a large field of view CBCT scan. So just trying to find the sources for her pain on both sides. And so again, here we could see where my mouse is hovering. We see that lesion associated again with number 14, pretty large abscess there associated with number 14. And so we found, one of the sources for pain on her left side, but again, she had bilateral pain. So let's scroll to the other side as well. And we can see that there's widening of that apical PDL space, that periodontal ligament space. So we can see that there's, some sensitivity there, apical sensitivity. So again, that's kind of, finishing the left side. But then if we look in the mandible, we can actually see that there's another lesion in the bottom jaw. So apical lesion associated with number 18. But then here's the interesting thing. So if we're looking this larger field of view cone beam, we could see that there are some calcifications on either side of the airway. And these are actually tonsil stones. And these are a cause for bad breath. These are a cause of halitosis. And so what's interesting is, we're able to see her dental issue, but also, we can see a reason for her halitosis, or one of her chief complaints. And then lastly, looking at the condyles, we could see some flattening of that condylar head. That's what my arrow was pointing to. And then we'll look at the other side as well. And we could see some flattening and loss of joint space. So, I know we can't see the joint disc, but to me, that signifies that we have some degenerative changes in the TMJ. So that patient might benefit from an occlusal guard or a night guard.
Perfect.
Yeah.
All right, so I got to thank you, Dr. Green, for spending time with us today. It seems like we learned quite a bit about cone beam imaging. It sounds like, as far as like the fear, if there's a region of interest that they probably want to narrow down to, it's probably getting into something that's more related to the pan that they're used to seeing today, but in 3 dimensions now. It sounds like when it comes to those studies, this sort of technology can really improve patient care and improve their treatment plan, possibly even change treatment outcomes by switching to cone beam. And then as far as education and support, you recommend taking some courses that will help them go through scan interpretation and do things like that. And they should be good with this sort of technology in their practice. So appreciate it. We'll turn it back over to you, Adam, at Henry Schein, if you want to open it up for any sort of questions that you have for Dr. Green or myself.
Absolutely. Thanks, guys. Awesome presentation. We've got lots of time left. No questions have been submitted yet. So Brent, I don't know if you've got filler questions at the ready, or you guys just want to talk for a little longer. But if no one's got any questions, you don't have anything, we'll wrap up a little early.
Yeah, we can wait for some questions. I know one of the things when it comes to using this sort of technology is, the education side of things. Are there resources out there? Are there online courses, in-person courses that you can think of that, you would guide someone towards to learn more about this sort of stuff?
Yeah, so there's an in-person course here that Planmeca offers, as well as an online component for those that don't necessarily want to travel. But I like to think of education in cone beam as you're investing a lot of money in the machine, so you want to learn how to use the technology. It's kind of like if you bought a GPS, right, but you don't know how to drive, or you buy a Ferrari and you don't know how to drive. You want to be able to use the machine, use the technology that you purchase. So I'm a big advocate for education as well. No matter if it's 3D or if it's CAD CAM, any new technology that you invest in for your practice.
I got to tell you a funny story, because I've got a mentor on the ortho side, Dr. Jack Fisher in Tennessee, and he's always said that, dentists, he goes, us dentists are interesting. We're the only ones that seem to buy these planes and then learn how to fly them after, right?
Oh, yeah.
So interested enough, like you said, you wouldn't buy this thing and then try to figure out how to use it after. And it's just, what the nature of our industry. So, taking these courses even ahead of time is the best way to learn. Download imaging software and playing around with it to get comfortable is probably a great thing for them to do. So looks like a question may have come in, Adam.
Yep. So we've got 2 questions from Betty. So the first is, what are key differences between different machines? Now, I'm not sure if she's looking for 2D versus 3D or just how Planmeca 3D stacks up against other 3D units. But then in addition to that, how about artifacts from other crowns, etc.?
Okay. You want me to take maybe the first half? We can bounce off each other on this sort of stuff. So obviously looking for machines that provide the field of view and the region of interest that they want is probably some really good advice. Having a technology that can grow with your needs is really important. So some of the things, for example, on our side with Planmeca that set us apart is our machines are built upon robotics. So these machines that are sitting behind our shoulders right here were built upon robotics, and it was developed that way so that they're software driven. That means there's no x-ray we can't take today or any x-ray in the future. So as these technologies change, you don't have to worry about discarding it and trading it in and getting a whole new machine. You've got something that will grow. So as we add new features and functions, you can enjoy those things and keep it current at any time. So for example, over the past few years, we've done things like automatic focus pans. So the staff don't have to use all these target lights to focus their pans. They can take extraoral bite wings where the staff have a better chance of opening up those contacts on a more routine basis and are better diagnostic than intraoral. Patient motion detection. So patients move. We talk about artifacts as one of the questions. how do you handle artifacts? You got to have good algorithms, right?
Yeah. So about patient motion, just on the side, because I see a lot of scans every day, and for me as a radiologist, I'd have to say the #1 detriment to image quality, it isn't the crowns or that metal artifact that you see from gutta percha or any restoration like that. The #1 detriment to image quality for me is motion. Especially if it's an ortho practice that's scanning a lot of kids, or even a GP that's scanning kids, or elderly patients. So patient motion really it really hinders the diagnostic quality of the scan.
Yeah, I think there was a study that was published on patient movement that put it at 25% of patients moved during a 3D scan.
I'm surprised that's not higher.
Well, actually, I think at the AOMR that we attended, they were given a sneak peek on a study that's soon to be published that was taken at north of 80%, because now, rather than just looking at regular patient movement, and they're seeing better quality images, they can see movement even more with the better quality images.
Okay.
And the broad-shouldered patients, right? So you have patients that might get brushed by the tube head. So those are taking up to, nearly, I think it was north of 80%, if I remember right. So we have an algorithm set in place. If a patient moves during a 3D scan, our software algorithms detect that, and then we automatically correct the image. And it's an industry exclusive that only Plan Mecca has here in the United States, which is fantastic.
Still going back to that percentage that you threw out, I guess I was surprised that it's not higher, because you get the periodic brush of the shoulder, or you get the patient with Parkinson's, or the kid that just moves a lot. I guess a lot of movement as well is just by breathing. It's these small micro movements, and sometimes, like you said, if you get a really good quality scan, you can see a little bit of motion. So what it looks like, or what you want to look for if you see a scan with motion, is it almost looks like there are two cortical plates almost. So when you're going down your axial or your coronal view, it almost looks like there's double contouring of the bone and the maxilla and mandible. So that can even happen with just breathing, and we all have to breathe, right? So I guess I'm surprised that the 25% wasn't 80 to begin with, but that's just my perspective on motion. I think it's
right.
Yeah.
What besides, I'm assuming, like you said, artifacts is what you see. Someone sends you a scan and you're looking at something and you're like, how do I call this office back and say, take another scan, which is concerning. So is it safe to say another thing that you probably see is, I joke around and call it 3D cone cutting. So you take a 2D X-ray, they call that 2D cone cutting, where you get an image and it's slightly cut off, and you see something that maybe the dentist didn't catch, and you really wish you could see that area a little bit better. Does that happen a lot?
Yeah, I think mainly for the maxillary teeth. If you're taking medium field of view and you're placing implants in the maxilla and mandible, if you're just taking a medium field of view scan, you're only going to see a little past the floor of the sinus, which is totally fine. But if you want to do a sinus lip, or there is sinus inflammation, that extends off the field of view. So for me, diagnostically, I'd like to be able to see, is the whole sinus filled? Does the inflammation run the entire length of that maxillary sinus? So there is something to be said for for seeing things at the periphery of the field of view, and then wishing that you could get the right diagnosis by having a larger field of view to see beyond what you're seeing. Right.
Yeah. Or having that luxury of, like, if in the future, like I mentioned earlier, if they want to bring on some sort of specialty or expand their practice into other specialties, they've got that luxury of getting a larger field of view and all that.
Yeah,
and
I call that future proofing.
Yeah, future proofing. Yeah. And, you know, back to the cutting off and all that stuff, and back to the question that was on the table regarding things regarding that are unique and all that. It's like, for example, patient positioning. I mean, it couldn't be any easier. It's a robotic arm that I mentioned, a little joystick. They can move the field of view precisely for that patient. Our VSO line allows virtual patient positioning, so they actually see the patient on the screen. And then with their fingers, the operator just adjusts the field of view to wherever they want based upon that patient's anatomy. So Adam, looks like maybe another question may have come in.
Yep. So can Planmeca 3D pair with like PrimeScan or another branded CAD/CAM system for a digital workflow?
Yeah, so if you're looking to take cone beam and marry it with your digital impression scanning, so maybe they want to do better surgeries with using guided surgery, PrimeScan, it doesn't matter, 3Shape, it doesn't matter which scanner it is, we can bring that data into our Romexis all-in-one imaging software, and they can do all of that planning under one roof. If they had our Emerald S digital impression scanner, which is hyper fast, easy to use, has some really cool features on it that other scanners don't have. If they had that scanner, they're actually in that same software scanning, and the staff are not bouncing back and forth to all these different softwares. They've got one software, one platform, and it makes it super easy. But yeah, we welcome anybody's digital impression data into our system with open arms, because we want everybody to be in this whole digital space. So.
Awesome. Well, those are the questions that came in. Any closing thoughts or anything else you wanted to bring to the table?
I think we covered up quite a bit. I know we're going to follow up, Adam, with it sounds like an email to the viewers that are going to have a special offer for those that attended, which is fantastic. But I think we covered just about everything we needed to today. So how about you? Do you feel pretty good?
Of course. It's been a pleasure. And again, if you have any questions about 3D imaging, there's my contact information. I live, breathe, sleep radiology, and again, with my dental background, you know, I just love this space of you know, merging dental and the diagnostics. So yeah, it's been a pleasure. Thank you very much.
All right, thank you, Adam. We appreciate you having us here and letting us host this.
Of course, thanks to both of you, and thank you to Planmeca as well for sponsoring today's webinar. Like they said, if you've got additional questions about CBCT, feel free to reach out to Dr. Green or Brent, or you can email us at webinars@henryschein.com. Additionally, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. Today's webinar was recorded, so that will be distributed within 1 week of today. Thank you all for joining, and hope everyone has a great weekend.